we're ready now for Jill Watson and Bob Robke to come up and present on ACOs. So that was the Hi, Bob. Just a second, get you guys going here. Okay. Jill is the, yeah, you guys can sit or you can be here at the, I do have a, Jill Watson is the CEO of Kansas City Metropolitan Physician Association in Kansas City, in the ACO. Jill, prior to March, Jill was Executive Director of the Metropolitan Medical Society of Greater Kansas City, or MetroMed, a large professional association for physicians in the Kansas City area. During her 16 years with MetroMed, Jill gained an extensive understanding of best practices in medical care and the barriers that keep physicians from achieving them. She left MetroMed in February to become the CEO for KC's first accountable care organization, KCMPA ACO, a transformative physician-led organization with the triple goal of better health care quality, more informed healthcare decisions, and lower total cost. Among her product successes at MetroMed is creation of MetroCare, a network of nearly 900 physicians who volunteer to diagnose, treat low-income uninsured patients. Jill began her career in Washington, D.C. as a public policy assistant for Honda North America and then the American Association of Homes and Services. She also spent 2 years with the American College of Obstetrics and Gynecologists as an assistant state government relations representative. She earned a Bachelor of Arts degree in political science from Hofstra University in New York and MBA from Washington University in St. Louis. So, and I'm going to go ahead and do Bob. So, Jill's going to start off giving us a good overview of ACOs, and then Bob Robke is going to follow it up with the IT challenges of implementing that and the reporting that comes out of that and everything around CIO or ACOs. So Bob's the Vice President of Cerner Networks. Mr. Robke manages all aspects of the growing business unit, including strategy, sales, marketing, pricing, packaging, implementation, and support. Mr. Robke rejoined with Cerner in 2007 to oversee the creation of the particular business unit, which has experienced significant growth since its inception. The Cerner network is a collection of connectivity services, including clinical transaction routing and delivery, e-prescribing, payer connectivity, health information exchange, and analytics, as well as patient services. Mr. Robke is a 22-year veteran in health information technology industry, beginning with a career with Cerner in 1990. He served a number of different technical roles, including systems engineer, integration architect, and technical project manager. Mr. Robke received a Bachelor's of Science degree in Computer Information Systems and emphasis in accounting from Emporia State University. Thank you. I'll let you guys go.
Well, thanks, Linda, for giving my background and Rob's too. I also went to Girl Scout camp one time, in case anybody cares. So I am Jill Watson. I am the CEO of, as Marty Ross mentioned, the only ACO that is currently in existence in the Kansas City area. We are super proud of that. You could probably understand from my background that I am a physician person from way back. I've worked for physician organizations really my whole career. I'm a policy person, not an IT person, not a clinical person. So I've spent my career looking at policy and healthcare, policy, where we'd like it to go, what keeps physicians from getting there, and the dynamics that exist. Through my career with MetroMed, of course, I got very familiar with physicians in the Kansas City area, the challenges of different systems, and it's clear to me that they definitely do want to do the right thing. They understand the policy goals that we're trying to get to. They also understand that the incentives, as Marty mentioned, are entirely in the wrong place. And so we are super excited about the opportunity to train, to sort of turn that upside down and see if we can help put different incentives in place so that doctors can do what they know has been needed to be done for a long time, and sort of been swimming upstream trying to make that happen. So I'm going to walk through a little bit of sort of what we've been through, how we got there. There is a whole bunch of IT stuff that goes into this, and Bob's going to talk about the breadth and depth of that. I'm not an IT person. We covered several things I'm not. So, but I am thinking through all of these things daily. So if you have questions about something that I don't cover here, we are a very transparent organization. Those of you who already know me know I'm an open book, so I'll tell you whatever I know about whatever I know. So we think that our ACO is probably the most exciting thing happening in the Kansas City area right now. Probably a little biased about that, I'll recognize. But all the change that's happening in healthcare reform that Martie so eloquently outlined earlier, I think there's a lot of bummers in healthcare. There's a lot of downsizing. There's a lot of, cost cutting. It seems, enormous. From the physician perspective, all the hospital integration that has happened because, hospitals are panicked. They're not going to get patients anymore, and doctors are not convinced they can go it alone anymore. It's kind of a bummer. And so this is a bright spot, I think, in healthcare where we're thinking, we can get a handle on this, just keep calm and carry on, and we're going to get this figured out. The doctors that I'm working with are obviously trailblazers. I'm super proud of them for being that and for being willing to stick their necks out early on. I thought that the first ACO would be probably an integrated health system of some size here in the Kansas City area, and that did not bear out to be the plan. We're one of 35 ACOs in the country that are in an additional sort of add-on. We are a Medicare Shared Savings Program ACO, and that Martie described, but we're also in an advanced payment program. So that is a program that Medicare layered on as a way to encourage independent doctors to get into this game. It was clear from the beginning that with the pioneer ACOs and all the giant health systems that were applying for this, that we weren't going to get the level of innovation that the policymakers were wanting if they didn't find a way to encourage very small physician groups to do this, kind of where the rubber meets the road and who's writing the orders, down to that level. We're very much down to that level. We are, our leadership team are all practicing full-time physicians. That's what our board is made up of. So they're definitely in it to win it. We do have a larger group. The KCMPA, we have two organizations, KCMPA and KCMPA ACO. It's very creative. And the ACO is a subset of the larger IPA. Our plan is to layer in the rest of those other groups when Medicare allows. I mentioned that the advanced payment program was designed for small groups. Part of that is that they have a cap on the total revenue that can be earned by all the groups involved in our ACO for a period of time. I think that was because that was a way to make sure a health system wasn't involved. But also made it pretty apparent we weren't going to include specialists either. So we had to meet two other hurdles. We had to have at least 5,000 Medicare patients and no more than $50 million in total revenue. So we have 12 small practices that more than exceed the patient. We have about 12,000 patients, and we certainly fit under the $50 million in revenue cap. So the fact that we have a primary care basis doesn't at all mean that we are primary care focused or that specialists are excluded. And it's exactly the opposite. We think the specialists are very important. They're very involved in our quality improvement committees and sort of laying the groundwork of how we're going to build our organization for the future beyond primary care. But there is a lot of focus on primary care right here at the beginning. It just has to be that way. So what we're asking them to do is prepare now by looking at, as Martie mentioned, I'm a big fan of the Choosing Wisely campaign that the American Board of Internal Medicine has put out. I encourage specialists. Lots of them are still pretty unaware of that campaign, and if you don't know what that is, you could Google it. But they have lists from lots of specialty societies of, 5 to 10 things that physicians ought to look twice at before they do things like imaging for back pain or, all different kinds of things, depends on the specialty. But helping doctors get aware of those activities in their subspecialty organizations, I think is helpful. We want to use this time with specialists to help them begin to think about those things. And it takes a while to get comfortable with some of the ideas, and so trying to use this as productive time so they can kind of work through that. And by the time we're ready to deploy, they're on board and they understand what we're talking about and are ready to make some suggestions about care. So the way we came to be an ACO was, some of you might recall that we as a community, and me at that time as executive director of the Medical Society, tried to get Kansas City named as one of the 7 markets for Medicare's Comprehensive Primary Care Initiative. That's what CPCI means. And so the employer community and then the health plans and our regional office here in Kansas City, we convened a lot of meetings around that and tried to make a good case that Kansas City should be picked as one of the 7 markets. We were not ultimately successful in that, but it was really helpful in getting everybody together and having people starting to think about, what could we do, what would work in our area. So Clay Platt CPFMC means Clay Platt Family Medicine Clinic. That is probably the founding organization, the one that took the lead to get the independent physicians together to form the IPA in 2011, and then eventually wrote the application for the Medicare Shared Savings Program in the fall of 12. And, it took, again, they're all practicing physicians, and at this time they had really no executive leadership. I was helping them as much as I could from the Medical Society, and Cerner was providing executive leadership on loan to them as well. But, mostly everybody had a different full-time job, so we were trying to figure this out under those constraints. As an IPA, we looked for funding. Those of you who work with doctors know they don't keep a lot of cash laying around. The tax code really incentivizes medical businesses, physician practices to zero out their books at the end of the year. So they don't have a lot of cash around to do these kind of infrastructure changes. So we were looking for partners to help, put up some money to do this, and nobody wanted to jump in first until the advanced payment program came up. So we applied to CMS, as I mentioned, for 2 programs, and we were awarded those. And in true Medicare fashion, we were awarded the shared savings and the advanced payment program on January 8th, and they started the clock ticking on January 1st, and we didn't get any money from them until February 20th. So, we feel like we've been running to catch up. We're that kind of burning daylight to make this happen in our 3-year window. But we're getting closer. It's been a good couple of weeks, let me tell you. So under our program, we are responsible for a panel of attributed patients. They are Medicare fee-for-service only, so this is not Medicare Advantage or any of those other programs. Had to have a minimum of 5,000 patients. We have close to 12. There are 33 quality measures that we're responsible for achieving. Most of them are focused around chronic disease. And Medicare is providing a cost projection of what they think these 12,000 patients would cost them without us. And so the name of the game is to figure out how to stay under their projection. We don't have any ability to impact their projection or influence that at all. We're not spending any time thinking about those kind of things. We can't do any gamesmanship on acuity or risk adjustments. That's sort of been taken off the table. So we are focused on having high quality and reducing unnecessary costs, pure and simple. So if the quality measures are met, as Marty explained to you, and costs are below what's projected by Medicare, the ACO has the opportunity to keep 50% of the savings to run our organization and the infrastructure that's built in it, and to provide additional compensation to practices, which if any of you are involved in running independent primary care practices, you know they're fragile financially. The advanced payment part, I mentioned that it's designed for physician-led groups. There is that additional hurdle of we had to stay below $50 million in total annual revenue. That's not total Medicare revenue, that's total everything revenue. So it was clear we couldn't include very many of our specialists or hospital partners or anything else like that. Timeline, we were awarded shared savings in December, advanced payment on January 1st, received our first payment in late February. I came on board full-time on March 1st. The first activity right out of the chute is we have to tell all 12,000 patients that their doctor is in an accountable care organization, because they have the right to not have their doctor receive their claims data. So in addition to the upfront savings that Medicare is sharing with us, they're also giving us comprehensive claims data on the breadth and depth of patient care that Medicare has paid for on behalf of our patients. So that for the first time, physicians are going to have data about what kind of care patients are getting not in their office. So nobody has looked at this. Nobody, maybe hospitals get data like that, I don't know, but from my perspective with physicians my entire career, they've never seen this kind of thing. So it's, we don't know what's going to be possible to get out of that data. We might find that there's diagnoses we weren't aware of, things they're being treated for that we weren't aware of. We might find that they have behavioral patterns that they really prefer to go to the emergency room rather than come to our office. All kinds of opportunities like that for us to look. We can't start getting that data until 30 days after our patients are notified. And we made a decision early on in March when we understood what this notification process was going to look like to these 12 small practices, to do our notification in a wave process. So we started with one practice in March. In April, we did 3 more. In May, we did 4 more. And in June, we have the last couple that we're going to notify. It generates quite a few questions, lots of phone calls to the practices. So from an infrastructure perspective, we have to make sure the training happens and their staffs know what to say. We certainly want to try to minimize the number of people who don't want to share their claims data, because that would make it less robust for us. And wouldn't, maybe not be as good of an analysis if a lot of people opted out. So that process, while it takes some time, is going very well. We are within the sort of range of 2 to 3% in opt-outs, which is as good or better than other ACOs experience around the country. So we got our first claims. Actually, a little ahead of this, we got the first practice, we got their data just a couple weeks ago. And so those claims files will continue to get more robust as the months go by. We began hiring staff other than myself April through September, and it has been really fast and furious in that way. So we have a team of care coordinators on staff now. We have a dietitian. We're working on a pharmacist. If you know anybody who might want to do that, let me know. So that we can deploy those. And I did not add a timeline. I did not add sort of what we're planning to do, but it might be interesting to you to know. So we have these 12 practices. Our plan is to let them continue to be independent. We're going to share data with them about, what their patients are doing, what their data shows about them. We are connecting them all, and Bob will talk to you a lot more about what it takes to do that, but we are making sure that we can get data from their different systems into our ACO so that we can report as a group about our 33 quality measures. But for the most part, we are not, we intend to honor the cultures and the practices that are involved. And I think there will be some evolution along time where we are able to show best practices and have people adopt those and embrace those. But we are not coming in and telling them, this is how you're going to practice with this kind of patient and that kind of patient. That's not the culture that we're building. I believe that physicians, they are competitive people, they understand data, and when you give them all that, they will go where where the best place to go is. And so that's what we're going to do. And that'll take a little time to roll all that out. But hopefully not more than 3 years, because our deal with Medicare is a 3-year program. So we have 3 years to show that the patients in our ACO get better quality care and cost less than if they weren't in our ACO. At the moment, we have 11,082 patients, and we've added another practice that we think has another 2,200. So we've got a lot of patients. A lot of ACOs in our category don't have nearly the number that we have, so that's good news. And then we're going to help the physicians, again, honoring their current cultures, provide better care through decision support, leveraging what they have in their own practice through their EMR system and any other vendors that they have supporting them, because this hasn't happened in a vacuum. Everybody's trying to achieve patient-centered medical home. Everybody's trying to get meaningful use. Everybody's doing all that stuff. And so all this dovetails together. The ACO is not some unrelated tangent project. It kind of is the thing that pulls them all together. And actually, for these fragile practices, provides them some more support and helps them be successful. Additional human resources is a big deal, and we're giving all the practices a care coordinator and a person to help them focus at least on the highest risk, maybe most expensive, just the people they think are sick and need somebody else to look at them and follow them a little more closely than the visits that the patient's coming in for. So those are the people we've been hiring. Those are the people we're deploying to their practices right now. And then analytics. Most physician practices don't have the capability to do the high-level analytics that are going to be required, and thankfully Cerner does, so we're going to rely on them a lot. The way it works, again, Martie mentioned a little bit about this. The ACO gets comprehensive claims data on all the patients. Providers continue to get paid Medicare fee-for-service in the same way they always have. Nothing changes about that for them at all. So our ACO will end up getting about $2.3 million over 18 months. You will notice that I told you this is a 3-year program, and we are going to get funding for 18 months. So that establishes an expectation that they think we'll be having either additional savings that Medicare would pay us for, or some other funding that would sustain us the rest of the 3 months. I mean, the rest of the 18 months to get us to 36 months. So that's a ball that I continue to keep my eye on, and we're figuring out how to fill that in, whether we stretch the money, whether Medicare will let you stretch the money that long, or whether or not we could fill in with commercial contracts, and that's very much on the table as well. So we will analyze and stratify claims data, identify opportunities to improve care and reduce cost. And for the time being, and I mentioned that there's kind of a time lag before we get the data. So what we're asking physicians to do now, and nurses and really everybody on their team, is to use their intuition and their clinical training. And data's important. I know this, you all are important. Data's a big deal, but so is your clinical intuition. And you know who's sick, and you know who probably doesn't have the right support system at home. Write them on a piece of paper for now, and let's try to figure out how to start working on those people right now. And then hopefully the data that we're able to get and analyze will support that and give us even more intelligence. But there is certainly work we can be doing and are doing right now on just based on what the gut feeling kind of is happening among the clinicians and the practices. And we're starting also to have conversations with specialists. They really want to know how they can support, and sort of asking them to consider changing the dynamic from I fill every order that comes to me to thinking about where is the physician who's ordering this trying to go with this test, and do I know a better way that they could get there, same or better quality with less expense, and to have that conversation, to pick up the phone and say, doctor, I think I know where you're trying to go. I think I understand what you're trying to look for here. I think we could do this without duplicating this test, or whatever is clinically appropriate in those settings. But to have those conversations, which for the most part really don't happen. They're, as Marty said, the incentives aren't there for people to make those conversations. In fact, they'd be silly to, from an economic perspective, to do that. So we're asking them to do something very different. And for the specialists, for right now, there is no other incentive other than it's the right thing to do and it's where we need them to go, and kind of a head start. But financially, there's not an incentive for them quite yet. We're adding care coordination, a pharmacist, a diabetes educator, interventions that are not really utilized now. It's not in primary care physician offices. Those of you who've been involved in healthcare a long time, you know that insurance companies have diabetes management programs, and hospitals have them, and employers have them, but none of them talk to the physician's office and are making it possible for the physician to leverage those resources. So they don't feel authentic, and they're really not used in a way that could be helpful. And that's something on my wish list, is that we can start to do that. To don't just be oblivious to the fact that your payer is going to call, or your employer has some other resources. I hope our care coordinators will really understand those things, really specific to communities. I mean, we're working with Hy-Vee grocery stores and dietitians in there because that's where patients go to get their stuff. It isn't an 800 number where they're calling, So sort of that's kind of the angle that we're talking about in using interventions that are not utilized now. Certainly I understand all of those things are available in the market right now, but they're just not really being used in a real way in primary care offices right now. Quality metrics, I mentioned they're mostly chronic disease. There's 11 of them that are not derived from claims data. They're derived from patient satisfaction surveys that Medicare conducts in the first year, and then the next year we'll do those ourselves. So the patient experience is also important. Again, that dovetails well into patient-centered medical home and lots of other even meaningful use with the patient access to their own information and that kind of stuff. So again, it definitely ties in. This is, just one more project to get them thinking in these directions. You can see there's lots of chronic disease here. No big surprises on what would be on Medicare's short list of things for us to be improving. So from a cost perspective, we do not intend to be a low-cost provider. We are trying to eliminate costs that can be eliminated. So don't pay twice for something if you don't have to pay twice for it. So let's, rather than just know that the patient had some labs done in their specialist office, go and get the results rather than draw the lab again. So, or have a system in place where those results are pushed to us, hopefully. That's what we're talking about. We don't intend to be the low-cost provider, and I always want to be, because lower cost isn't always better. We're trying to identify best practices, and if somebody has a secret sauce on how to do a procedure and it costs a little more, but there are no complications and the patients always do better, we will go that way. So we are initiating conversations, as I mentioned, between physicians. I think the power in what we're trying to do is a physician-to-physician communication and having them understand what the needs of the patients are and agree that we can get to where we want to go with this patient by doing these things, and it doesn't have to cost more than whatever it needs to cost. We will not impede referrals. A lot of people want us to say that we're only going to refer here or there. That is not on our short list of things to do. I'm hopeful that data will bear out and it'll be obvious where people want to go, maybe. Or maybe we'll find that there's not all that much variation. So we don't expect that we're going to change referral patterns anytime soon. And I mentioned that we're trying to reduce expected costs, but not pay less, absolutely. These are the practices who are involved and kind of the size, the number of patients that they have in our ACO. And then a little bit about the bigger organization, which is called KCMPA. It is an independent practice organization. It's been around for almost a year longer than the ACO. So it's an affiliated but a separate organization. Medicare, we couldn't have physicians involved who were not in the ACO, and so we had to set up a separate tax ID number and a corporate structure. But in the IPA, there are 200 additional physicians in multiple specialties, and we are continuing to consider them at least a farm team. I mean, they're the second tier of the ACO. We have every intention of adding them into our ACO as soon as our revenue cap is lifted and, you know, Medicare is okay with all of that. So we are connecting all the electronic health records in all of the IPA, certainly the ACO, but we're connecting everyone. So we're going to be able to share data in a different way than we've been able to, like right now. This is happening this minute. We have a connection with LACIE, and who you'll talk about later. And as I was interested to hear Martie's comments about bundled payments, that's the first question that every specialist asks me is, do we have those? And no, we don't. That is, we feel real strongly that there's a lot of trust building that has to evolve before we could get there. We think that a physician-owned organization has a better chance of achieving a level of trust that would facilitate that than a hospital-owned ACO, but that's, again, just my bias as a physician-owned organization. So we're not there yet. We wouldn't rule that out necessarily, but you know, that's something that we would talk through. Our physicians would go through. You know, we would have to develop formulas. That we don't have anything on the back burner that would tell us how to do this. We're watching that just like everybody else is. So more to come, I guess, later on that. I mentioned about specialist involvement, and I have no idea what time it is, Bob. So am I into your spot? Okay. The revenue cap goes away after 18 months in mid-2014. We have specialist involvement on all of our committees, which are quality improvement, which includes education and care coordination, finance, compliance, and we are asking them to understand their quality and their cost benchmarks, which is kind of hard. You know, it's especially the cost part. Nobody has any idea what they cost compared to somebody else. So we're, as I said, introducing them to the Choosing Wisely campaign. We are looking at quality measures on just about every subspecialty has something that's been through NQF. So there's at least a measure that they can be looking at. And some subspecialty societies are way, way far ahead in terms of they've been tracking quality. You think about cardiothoracic surgeons. I mean, they have an extensive registry that's years old. So they all know exactly how well they do and what their complications ought to be and whether they're out of range. I mean, they all know that. So there's probably a lot they can teach primary care in that way. I have 25 minutes, including Bob? Yeah, okay. So I mentioned early on that there is a lot of IT. It is just impossible to think about doing an ACO and not just be overwhelmed by the amount of IT projects you could possibly do with this concept. So we've got 3 pretty, giant ones, I think, on our plate right now, which is about all the capacity we have at this point. And I think Bob's going to talk in a lot more detail and relevance to you about what those entail. But they're very exciting. But we're moving along, not waiting for those. Again, based on just clinical intuition, what's your gut feeling? What do you feel like we ought to be working on now to make an impact on providing the highest quality around those 33 measures and reducing unnecessary costs to any extent that we can. So with that, I think I'm done.
Hello, everybody. My name is Bob Robke. I am Vice President at Cerner. I run our various connectivity services, and a pleasure to work with Jill and her team. I'm going to go through a little bit and try to be as transparent as I can with what Cerner wants to get out of our connection with the KCMPA and especially the ACO. Is, you guys hear me all right? Cerner's been obviously in the EMR business for a long time. As of the last 5 years, we've been really into more of the health side, including our own populations of employees, driving down costs associated with not only cost, but the outcomes and quality within our population of Cerner associates, and have been very successful and have lowered, actually reduced the per patient or per member fees associated with our healthcare plan over the last 2 years. So it's been a really good success story, but we also know that in order for us to make this a business model, we have to get on the front lines of true healthcare, which represented in the independent physician community and have been, I think, a big part of, or a supporting part of, the formation of the KCMPA and then subsequently the ACO award last fall or last winter. So I'm going to speak a little bit on the technology. That's Cerner is actually looking for models for IPAs because of barriers around capital, as mentioned by Jill. How can we invest in IPAs not only within the Kansas City area, but how can we make a model that not only from a technology standpoint, but from a people and process and know-how that we could replicate in other geographies. So I will speak through what we call this an enterprise data network versus an enterprise HIE. The reasons why we are calling it an enterprise data network from our standpoint is that it's really around the aggregation and the use of data for purposes around ACO and quality improvement, et cetera. And HIE is a function of that, but there's also claims data, there's PHR data, there's all sorts of information that the ACO, especially the KCMPA, and especially the ACO will need in order to manage those patients going forward. So we're calling it a data network, and it is a truly an independent organization. So one of the first meetings I went to that had the physicians on the board of the KCMPA, that came through pretty loud and clear, is that they wanted to remain independent, but they had no capital to really do anything. So it was one of those where traditionally an IPA would look for funding from sources outside of their own organizations. And so their desire to remain independent was their number one, at least it came across to me as one of their number one goals. So then we go, okay, well, what can we do to help this organization? And we knew that there was a lot of barriers. We knew that there was no way we would be able to implement technology and expect capital to pay for the infrastructure. Even if we provided the people resources, et cetera, there was just no way to even broach that subject. So we knew we had to invest in some of this to help them. We also knew there was a huge variance of EMRs. Jill mentioned there's 8 EMRs in the ACO. There's 23 EMRs in the IPA total, 23 different EMRs, none of which are Cerner EMRs. So we get into the discussion this morning was great because currency's the new, or data's the new currency of healthcare. The problem is everyone's really tight. Nobody wants to provide very easy ways to get to data or ways that are very cost effective. So of the 23 that we originally talked to, about half had no concept of what we were trying to even talk about in terms of exchanging data. Not even standards, just what can you provide us to provide some sort of shareable summary of information across the KCMPA practices. And so we ended up going forward with, I think, maybe a dozen, but there's probably 5 or 6 of those that have to do development work, which goes to the point of there's a huge chasm in terms of data is the new currency, but vendors, and even Cerner for a long time, that was not high on our list, was be as interoperable as possible. But that has changed. I mean, now data is actually, has to be there for these things to work. It's a part of it. It's not the whole thing, but it's a part of it. And so we've got a lot of industry education to do, not from a Cerner standpoint, but from, we need these EMRs to be able to talk and talk in a way that's affordable. So we have a lot of challenges to do. We went ahead and, you know, like we do every day, we arm wrestle and we challenge and we get moving forward. The ACO has some additional capabilities around needing to go a little quicker, so there's some additional technologies we're putting in for the ACO that will sidestep some of the vendor problems that we have. The other thing is we communicated out to the physicians of the KCMPA that you know, our strategy around helping them, but also how we are going to fund this from a business standpoint, and I'll get into that here in a second. And then you know, in essence, we from a Cerner standpoint want to fit into the KC market. We've tried over 20 years to figure out how can we affect change in Kansas City. So we've had things like Care and Trust. We've worked with employers. We see this as a huge opportunity for us to one, learn a lot about what happens on the front lines of an ACO or front lines of physicians as they're the first, they're the gatekeeper of these patients. And then what can we bring to the table from a IT process, people, know-how, into these organizations. So that's kind of our goal. And then the challenges obviously are, I think we all have experienced some of those challenges. So this is a very crude drawing. I'm not really creative on my slides, so I apologize. So this is the KCMPA. We've created an enterprise data network here. Because of the uniqueness of the business opportunities within the KCMPA, we felt that they needed an infrastructure of their own. And most of this thinking right here was prior to the ACO. So an ACO is a good example of now they have some new business opportunities that they need to probably use data differently than if they were part of a larger health information exchange in the region. So we felt that their data network had to be flexible enough to handle whatever business opportunities that they needed to, one, get data, or two, provide data to other folks. Lewis and Clark Information Exchange, Mike Dittemore is over there, I saw him, is a regional health information exchange. So we will connect the aggregated group of physician offices that we can get the information into this data network, into the regional network through LACIE. LACIE is a hybrid model of a health information exchange, can connect through a federated model, can control some data centrally, but will broker out to the community for the KCMPA. We have a referral tool and a results delivery mechanism that I'll get to here in a second. Okay, so as I mentioned, what we're implementing in the KCMPA, 23 different EMRs across how many practices, Jill, in the whole MPA? Is growing. This is this may actually be a little bit outdated, but 30 or 40 different practices, most of which are smaller independent practices. So we're putting a query-based exchange in using some of the certified data systems technologies that will allow them to share data electronically amongst those practices, as well as with Lewis and Clark Information Exchange, which is connected to some of the broader institutions within the Kansas City metro area. Patient summary data, usually the continuity of care document, other kind of documentation that they want to make available. We use, for those that are technologists in there, this is a XDS type of infrastructure, along with all the IHE standards associated with that. does manage some low-level normalization of data, so we can convert things like first data to RxNorm and those sorts of things for use down the road for like the ACO, et cetera, as well as for viewing of information so we can collapse views and things like that. It provides, from a business standpoint for the IPA, I think it provides the IPA, and I have a little bit of experience with another region where I was at prior to coming back to Cerner, where there was an infrastructure that the physicians owned. It was theirs that they could aggregate information or aggregate connectivity streams so that not every organization connecting to them had to go do it over and over and over. In today's environment, most healthcare organizations are paying for those connections to the physician offices. Quest, LabCorp, hospitals, other service providers are usually paying the full freight to get information electronically sent out to their referring systems or referring physicians. And what that means to the practice is while there's no capital usually, there's tons of connectivity points that are not managed centrally, as well as there's a repeating of licenses for every one of those connections. So if Quest pays for NextGen's lab interface, so does Shawnee Mission, so does KU, if they're all connected to them. So there's really no economies of scale we're getting from a connectivity standpoint in today's traditional model. So what we've done is we've purchased most of the interface licenses and the connectivity licenses from these vendors on behalf of the KCMPA. So we'll reuse those licenses across many different connections versus every vendor or every organization having to repurchase those. And our business model is that Cerner is the one out creating those contracts for the organizations to send data in. And from a business model, that's where we want to recoup our costs of putting some of this infrastructure in, is that we would go to hospitals, imaging centers, other places, and have them pay Cerner to feed the KCMPA practices with data. Should be more efficient because we have already purchased a lot of the licenses. We've already have the infrastructure there and then the people. So we are seeing if that is the model that we can play out to at least cover our costs around the technology infrastructure. As I mentioned, results delivery. So pushing results. So there's, as I mentioned, they're inside the KCMPA and using LACIE as our broker to the community. We provide a summary of information from a query standpoint. So, and that's what we're implementing today. We're also have several organizations that have started up with the results delivery. So we are within the KCMPA, as I said, we purchased most of these licenses. So we are starting to implement results delivery from those organizations to a select group of the KCMPA physicians, some of which are the ACO physicians. We're using those licenses that we purchased and the technology from Certify to provide a single point of management of those interfaces. Routes off clinic, HL7, this is typical results distribution stuff. As I mentioned, we invested in the EMR licenses, and those range from anywhere from a few $100 to several $1,000, tens of thousands of dollars. So it's an industry that has not really settled on how these interfaces work, typically because the physicians don't have to pay these, typically. So some EMR vendors are tens of thousands. Some realize the value of connectivity and price them very low. It's just a matter of who we're dealing with and when. As I mentioned, we consolidate. We contract with different suppliers of data to the KCMPA, and we charge fees for that to those suppliers in order to recoup some of our investment in the licenses as well as the technology and people. Populates directly in the EMR. At that point, at least from the ACO standpoint, we do have discrete data within the EMRs that now, from those organizations, that now can be pulled into those broader analytic tools. Direct referrals. Now, this is something that's probably a little bit new to Jill. I know you've probably been brought to you, but we have started in Kansas City, especially in the, I think it's KC CareLink, a network of underserved clinics in town that do a lot of referrals between Swope and Truman, and those that have a standalone referral application that communicate not only referrals, but the status of those referrals, et cetera. And it's a little different model than a typical referral system in that it's an open system, meaning that a physician can send referrals to any place that they want to. It's not tied to a specific organization. So what we are doing now is going out and connecting with, these are the ones that are currently live. These are all part of the KC CareLink connecting into Truman. But expanding that out to the KCMPA, other hospitals, other referring centers, in an effort to provide a single tool at a very low cost to the community in order to, one, initiate referral, two, manage those referrals in terms of knowing when they're scheduled, when have they been accepted, have they been seen, and so there provides a little bit more of electronic infrastructure. Very simple, but it is an electronic infrastructure for that, which for the most part occurs on paper and occurs on phone calls and faxes and et cetera. The other interesting thing to this is we're going down the path of, I think you mentioned the referrals is typically within a physician practice unscientific in terms of how they refer out. And so we think there's also opportunity to provide a little bit more data for the referring physicians and their staff of where is the best place to send this patient within the confines of the plan they're on and within for quality. So who does the best knees in town? Who does the best knees in town? And also from a patient standpoint, they want them to be a female physician. So these are all sorts of things that we want to provide into this same infrastructure as a little bit more knowledge as to who is the best or who is the best based off the criteria of the patient or the provider. So that was quick, and I would really like to get to some questions. I know I don't think there's been one question yet, so I'd like to hear some questions before we finish. Yes?
What was going through my mind as you were talking, is there so many participating independent providers, how are you getting the authorization from the patient for the participation?
There's consent there's a consent process here, up in here, that, LACIE also has a consent process around treatment payment operations. But there is a consent that has to be reviewed prior to, the technology infrastructure being there. Basically, patients consent to share their data within that infrastructure.
It's just interesting because, of course, I work within a health network, and when we consent to that, it's easier to say, hey, these are all our providers, but now you're talking about people that don't.
Well, yeah,
would be sharing information,
well, yeah, and, if you look at one extreme, HIPAA does not require consent for treatment payment operations. I mean, so there's some folks that say, I already have the consent. I don't need to go through an extra piece. I see Joy in the background. We've talked ad nauseum about this. But typically, when you come to electronic type of sharing, you do want to provide a little bit more transparency to the patients that their data is available as they seek care across the community, unless they opt out. And I think that's the model that LACIE has, and that's the model I think that KCMPA has. But, consent is another barrier. It's a barrier in health information exchange in general, is the interpretation of consent. When do you need it? When don't you need it? Et cetera. Now, there is a different level of consent for the ACO that Jill went through that requires a little bit more because you are getting additional information that is not necessarily part of your treatment payment and operations. Yes? some-
Do we have other questions?
Yep.
Thanks.
Hey,
Hello, testing? Got it? Okay. I was curious, could you talk a little bit more about the integration of the claims data? Yeah, I think that's data that can be operationalized now. I know it's retrospective as opposed to all the heavy lifting that's going to take place to integrate the EMRs. I think there's some low-hanging fruit.
yeah, we currently are working on the claims data we got from CMS on the ACO today for the KCMPA. So yes, there is claims data is absolutely necessary. It's probably the fastest one to start with. However, you don't get the fidelity that you get from a clinical. So you need both, I think, to really operationalize going forward. Did I answer your question? And you can disagree or agree.
No, I agree.
Do we have other questions?
The other
One
thing
more.
that's kind of been a challenge, again, from a more practical, operational, is just, so we're presenting these 33 quality measures to practices and asking them to be thinking about how they can get their data out of their system. And most of their EMRs are not really very helpful in getting this kind of reporting out. In some, it's a giant understatement, but, so, you know, just sort of the move of technology from looking at a single patient and keeping everything you know about a single patient to starting to figure out how to look at your whole panel of patients is like way harder than I thought it would be as somebody who doesn't know anything about IT. And it's super, super frustrating to the doctors because, you know, if you look at the quality measures, there's not anything should be that hard for them to get. These are all things they're talking to people about, but still they can't, you know, they struggle to get it out of their systems. And as Bob said, some of the vendors want to be helpful and some really aren't. And so, you know, just to not have the vendor community tracking along with the move to
Yeah.
population health and to, like, you know, helping facilitate a look at a full panel of patients as opposed to one vendor at a time is just so annoying and expensive and.
Well, yeah, some of these vendors here has taken 9 months to get a quote on what they potentially could do. So it's it's frustrating because I think people think, you know, here the data's new currency. We got to get, and then you get into, you know, I think that I would call it the second tier, especially EMRs that just don't get the demand from their physician practices yet to make their data as liquid as possible. And so there's just a lot of work goes in just on not the technology side as much as just getting the vendors to the table to understand even what their requirement would be. And that is frustrating. Yes.
Well, we have been interested in the enterprise data network, and that implies a physical connection. Can you elaborate a little bit on that connection between the
This one?
KCMPA data network?
This one right here? Or
The whole green box,
the whole green box?
yeah,
Um,
and how they're actually connected.
Yeah, so within that is a query-based system. So what it means is we get patient summaries from these various sources of EMRs, and within there that little green boxes, they have their own method of doing that. And then that method here, this is kind of an aggregator, and then that method here connects to LACIE in one connection. So within this, think of this like its own, like a hospital or a health system that had 23 different EMRs in it that were, you know, saying we're going to keep the EMRs and try to figure out how to get the data out of it to do what we want it to do. It's really no different than that, other than their primary care, small offices using anything from a next-gen system to a DocuTab system. And I'm picking on DocuTab. Yeah, think of the practices having electronic charts available that I, within my EMR, can go out and say, hey, I have Jane in front of me. Show me the summary within the KCMPA. I can move it out to give me a summary of the community based off my LACIE connection. And then wherever LACIE connects to can get you to a broader set even from there. Does that make sense? Okay. Purely query, right. And this is this is purely federated too, meaning all the data still kind of lives on the edges of those systems.
Are those smaller systems all sending ADTs over to LACIE?
Yes, there is ADTs. Well, there are ADTs coming into here. The LACIE connection is through what we call XCA connection, which is, we use think of it a real-time MPI, or real-time demographic match. And once we find that, we do all of what we would normally do on a health information exchange. There is a potential we could bring ADT down in here too, provide LACIE kind of a like a record locator. So there's tons of different options in there, but depending on how we scale that out. Any other questions on that?